Let me introduce the speakers. Our first speaker is Dr. Reena Bhargava. Dr. Bhargava is an internist, clinical informaticist, and lifestyle medicine specialist. I can never get that. With 20 years of experience in virtual and digital healthcare. Former medical director at Kaiser Permanente. She has been, instrumental in development of e-visits, CDS tools, and population health programs for over 4 million patients in Northern California. And I've been privileged to know her in her work. She's amazing. So welcome, Reena. The stage is yours.
Thanks so much, Julie. I am in such amazing company. It's truly an honor, and amazingly fun to be in this session. For the folks out there, thanks for joining us. This will hopefully be an insightful and informative session. As Uli said, I have spent about 20 years as a medical director at Kaiser Permanente in Northern California. I had a practice of a few hundred patients, so I was a practicing internist, as well as built these clinical decision support tools for our telehealth platform and our digital health platform. I led the development of electronic visits. We launched that in 2018. The patient platform, the physician platform. I've published about it in JAMA Online as well. Done a lot of work in women's health, gender bias and lipid management, osteoporosis screening and treatment. We've presented them at international conferences and American Heart Association meetings, etc. So last year, I pivoted and moved away from Kaiser. And the biggest push for me was AI. As I looked at what was happening, and for the fact that the last X number of years, I was deep in data as we made clinical decisions, evidence guided and everything else, with maybe even 300 million encounters at a time to say, what about this? What about that? To try and create the best patient experience and efficiencies for the physicians who are always overwhelmed. I thought AI is an amazing tool. I'd been really impactful in my work. I was told by my chiefs and the, high up in leadership, my work was touching millions of lives, and I wanted to do something impactful outside Kaiser. So that's my, opening for where I am today, building BioTrax AI, a platform that helps doctors, built by doctors, helping doctors, bringing longevity and the latest and greatest in preventive precision health. It's the core of what physicians do, but we needed AI to bring us to this whole different level, and it's opening it up to our physicians, their patients, to health conscious consumers with actionable insights, total integration. It isn't replacing the physician, it is augmenting the physician, empowering them with a lot more that they can do. So that's the journey, and happy to talk some more as we go along. Thanks, Uli.
Great. Thank you very much, Reena. All right. Our next speaker is going to be Dr. Paula Muto, MD. She is the CEO of UberDoc, founder and CEO. She's a general vascular surgeon with 20 years in private practice, also leads UberDoc, and it is the largest direct pay specialist network in the USA. And she's a passionate advocate for patient access, women's health, and price transparency. Welcome, Paula. The stage
Well,
is yours.
thank you, Yuli. It's very nice to be here and welcome everybody. This is always such a great forum, Innovator, and I congratulate Yuli and Ruchi and their team for always putting together this wonderful forum. So my story, I'm a surgeon, I always say from birth, from a whole family of surgeons. I trained in just both general and vascular surgery, went into a private practice just north of Boston. And we'll get into, I guess, the discussions about private practice. But I actually was in private practice pretty much my entire career. I had a child while I was a fellow at Leahy Clinic in vascular, and had my second child when I was in my second year of practice in private practice, and then took a 3-month unpaid maternity leave, came back and lost my job for being away on maternity leave. so, so then
Good
I
old
said I was
days.
never going to work for anyone again. Um, but anyways, I ended up in my dad's office with a thoracic surgeon, and I just kind of called up the insurance companies and said, okay, what do I do? And then I never looked back. I had a lot of support. My husband's a surgeon as well, my brother, 2 uncles, and so forth. I built a career in both general and vascular surgery, taking a lot of call, still on call, in fact, on call tonight, trauma call, every kind of call. I started a breast clinic. I started a wound clinic. I was a big believer in women's health as well, but every breast lump had 2 carotids, so I like thinking about what other things that we don't pay attention to in women's health. So always with an eye toward, that why are we just focusing on one? So I was really very passionate about that, and bringing in a lot of different specialties as well. That's sort of like who I was, a disruptor, always sort of agitating in the CEO's office saying, we can do this better, faster, cheaper, build the breast centers, build the wound clinics, do these kind of multidisciplinary, just kind of get things done faster for patients. So I built I kind of went into my own private practice with most, like a lot of vascular surgeons, arterial vascular disease kind of fell away in terms of intervention. And I, being an old fashioned open surgeon, I moved into the endovascular world of the venous world and started a vein clinic in my office. So I was doing office-based procedures. So I kind of work in the hospital and then sort of built this ambulatory venous center that became nationally certified and so forth. So that was sort of an interesting thing for me. While I was there, I realized, it's really important to be front and center to the patient. I'm in Massachusetts. I lived through all of it, pre-Romney Care, HMOs, Romney Care, Affordable Care Act, on the front lines, trying to run a practice, and really began to understand the economics of this that was getting more challenging. So I wrote a lot of angry letters, and then I decided I could keep writing angry letters or try to do something about it to essentially preserve the doctor-patient relationship, make sure that like specialists, like people could find you. Everyone had a shot. Every independent doctor should be out there. So I created a very simple technology platform to connect patients to doctors for a transparent price, eliminating all the insurance, the network restrictions, and just make that price affordable. And that was what UberDoc became. So I started that journey 9.5 years ago, and here we are. We're scheduled to go public in the Canadian markets in mid-October. To bring this out to consumers in a big way. We did create the biggest network of direct pay specialists in the country. And I realized that the entire mission has always been the same. We talk about access and price transparency. This is what we're doing, but really it's to preserve the doctor-patient relationship, because technology has given us so many wonderful tools to connect with patients. The system has gotten in the way in a lot of ways, and now we're kind of coming full circle where patients are at home, patients are monitored remotely. We have all these AI technologies, we have these remarkable medications and treatments, and I kind of feel that preserving the doctor-patient relationship is really what the core of my mission's always been. So it's really great to be here. I'm really looking forward to all the conversations that we're going to have about just the economics of private practice, about the concept of direct pay care, and where the healthcare system is kind of moving toward in a lot of ways. So I really look forward to the conversation.
Great. Thank you very much, Paula. So one tidbit about Paula and InnovatorMD is that she was the first startup to join InnovatorMD when we
Really?
first started our first conference
I
way
was in
back
the
ago.
first batch. I know. Yeah, that's right.
You're
At
you're in the first batch,
first conference
and
and it was our only live one. So we really need to do it again. We need to be together live.
yeah, yes, we need to do that. And so I have seen the whole journey. Now
Yeah.
they're going to be, on Canada stock market and all that. So it's a pleasure, and it's a privilege to watch this and be a part of it. Thank you very much, Paula, for your support and for your grit to make this happen. All right. Our next speaker is Dr. Veronica Zhao she's the CEO, physician and CEO of Avid Sports Medicine. She is board certified in internal medicine and sports medicine. Dr. Zhao founded Avid Sports Medicine in 2019 to transform fragmented pain and injury care. With a background spanning elite athletes and underserved patients, she brings fresh insight into the modern private practice model. Welcome, Veronica. The stage is yours. Introduce yourself and tell us your story.
Sure. Thank you. Thanks for having me, everybody. My story is that I'm an internist and sports medicine doctor, and I've been practicing sports medicine for about 16 years. I worked in a lot of traditional practice models, large groups, on college campuses, and in smaller private practices. And I felt like it wasn't really how I wanted to deliver care. It felt fragmented, and some of the best outcomes I saw in sports medicine was at the college athlete level, where the training room model involves bringing everyone to the athlete, and that's how they get better. So I wanted to take a similar model to the everyday person. So I created Avid, and we've had an integrated approach. I focus on regenerative medicine, and I have athletic trainers and that are integrated into the model, so they do the care alongside with me. And we also have partners in chiropractic, massage, nutrition. So really trying to take care of the whole person. We've also integrated movement, so we offer fitness and wellness for our patients as well. So that's a little snapshot. I've been open for 6 years, and yeah, it's quite an adventure to run your own practice.
Thank you very much. Great. So, uh, so these physicians that you see today on the panel, these three physicians, they are each in a obviously different specialty. They come from different specialties, but also they come from different backgrounds. And they are looking at doing things differently. Each one of them have their own way of practice, and the way they have um, pivoted into what they're doing right now. So, well, as a first question, I'll start with Veronica. How did you make this change where you are at this stage right now? What was the pivot point, and what were the reasons, and why did you make that pivot? Okay, you may be unmuted.
Now I'm on mute. I think I have a little bit of a less traditional story for how I got here. I have been thinking about starting my own practice for a while, and hadn't gotten up the courage yet, but I had sort of taken an interim step and was the medical director for a startup. It was a sports medicine startup at the time, and that was a year that I did that, and then that company wasn't able to continue because of funding reasons. And so I was at an opportunity to figure out what I had to do next pretty quickly. I decided to take over the space that the startup was in, and take the parts of it that were the clinical model and make them my own.
Great. Good reason. Obviously, it seems to have worked out well for you. Reena.
When you're under pressure, yeah.
Yeah, yes, you're forced to pivot. Reena, same question. What made you pivot from what you were doing before to what you're doing now? What were the pressure points or pull or push things that worked, to make this change happen?
Great question. There are turning points in everybody's life. For me, I must say, I felt really, really good working at Kaiser. It's an amazing system, integrated technology, amazing set of resources as far as wanting to do data analysis, do the best for your patient. And the model by and large is preventive health. So kind of in our DNA. I did an NIH fellowship even before I started at Kaiser at Stanford in insulin resistance, metabolic syndrome. Used to be called Syndrome X. With the chief of endocrinology, there's Jerry Reeve and Gerald Reeve, M. Reeven. And so would be there at 6 a.m. doing insulin clamp studies on patients who'd been put on, say, 3 weeks of research diet, with huge insights into how lifestyle and so forth, medications. We studied doxazosin, but we did a ton of work on high fiber, high carb, this, that, the other kind of diets. And the fact that they had huge impacts on cardiometabolic profile, the risk for heart disease, all of that coming together, that kind of was baked into everything I did further on. And then lifestyle medicine happened as board certification. And I thought, why not? That was evidence-based, like all of the things we were doing, but let's put the stamp of, rigorous literature and evidence and, get certified, board certified in that. And then I was doing a ton of work on the digital platform for Kaiser, 4.5 million patients, population health projects, essentially tools for care delivery, virtual care delivery. We did telephone appointment visits like 15, 20 years back, video visits, a very strong platform with clinical decision support tools, maybe 10 plus years back, electronic visits that I launched in 2018. So then clinical informatics became a board specialty, and I thought, why not do that? So I brought all of that. And as AI came along, I thought, here's an opportunity to tie it all together. And essentially, I wanted to do something impactful. Physician colleagues of mine who are all overwhelmed, let's face it. And then there's a challenge for them in private practice. Their practices are being gobbled up by big health insurances. And then, the next year and the next year, they feel the squeeze and, the reimbursements are not that good. So that's kind of one concept of where just supporting them. And here's a platform for to do. And then there's longevity medicine. We weren't talking longevity medicine in clinics. We weren't talking about biomarkers. Those kind of tests are not being covered by insurances, any kind of insurance out there. And yet there are health conscious individuals who are talking about it. This is kind of mainstream and so forth. And my concept there is to expand the scope of our private practice physicians, give them the tools in an integrated fashion, support it with, say, an AI knowledge board, actionable insights, collate all of this in an evidence-guided fashion. So it's doctor-driven, it's doctor-built to empower our colleagues, increase their scope of practice, increase their reimbursements, their revenue stream as well, and most importantly, feel good. Preventive medicine has been the core of what everybody does, whether we're internists or cardiologists or sports medicine. Hey, heal this, but then do these stretching and strengthening exercises so you don't hurt yourself the next time. And in that same vein, there's so much happening with biomarker testing, predictive analytics, and so forth, that can be put together with a digital dashboard with integration of all our data points, our EMRs, our wearables, and test results, and so forth. But yet give it to a physician so that they're not overwhelmed by that. And we support them through this. So that's some of it.
Great. Thank you. So Paula, you've been, in a physician family, physician practice family, everything is going smooth, practice, see patients and all that. Why did you pivot into a startup mode, doing UberDoc? What was the What was the
Everything
turning
going
point?
smooth. I always start with the patient, right? It's smooth. So again, there's always frustrations in practice, right? And things aren't always fair, right? You work hard, you get paid 80%, you see things around you that aren't fair, and it's always like, after a while, it's like you look around you and you say, you see how you do things, you see how to take care of your patients. And I think Reena is exactly right. A long time ago, I worked with both family practice residents and surgical residents. And, I was always talking about, like, you got to think about the diseases of longevity means it's lifestyle limiting diseases, not life threatening or limb threatening, right? Like the pivot is, in fact, occurred in medicine, where we really are looking at, like, as a vascular surgeon, when I first started, I had to only give my patients a 3-year warranty, right? I do these wonderful tibial bypasses, really fancy. And isn't that wonderful? If they died with their legs on, that was great, because they were going to be dead in 2 or 3 years. But then they started to come back to me. Now their graft was down, and now it was 3 years and 4 years and 5 years, and they keep going. And so in my old days, I would have been like, oh my gosh, I got to go back in and do another intervention. But then it's like, I call it the Princess Bride philosophy. Well, maybe I'll kill you in the morning, right? Maybe I'll come back in another week, come back in another month. And now it's a year, now it's 6 months, because now there's a statin. Now their cholesterol is controlled. Now their glucose is controlled. Now maybe my operation wasn't really that impactful after all, because my graft went down, but that leg was still there. So you began to change, and I did a lot of wound work, and I got these wounds to heal in all sorts of different ways. So the pivot really is your patient. Your patient began to change it, right? So as soon as I saw that the equation started to change in medicine, right, and our system didn't recognize it, in fact, on the contrary, they were consolidating. They were creating, like, things that we all had to do to all our patients all the time. And I saw that we were going backwards. All the progress we were making suddenly we went 180 degrees behind. We weren't getting people out of the hospital. We were putting them back in. We weren't trying these other conservative managers first to buy time. We were going after the big intervention. And I think that was the friction for me, was that frustration to see that people weren't seeing it, weren't looking at was in front of us. And ultimately, our system really failed how we take care of the patients, to the point where, it got me to the point where we got to put the credentialed smart people in front of the patients first. The people that went to medical school. Let's put the people who practice medicine practicing medicine. And I just felt like, I think that, the pivot for me really was the patient moved, the technology moved, the longevity changed the equation. Like, so all of a sudden, all these diseases we didn't care about 30 years ago, like venous disease, we didn't care because everybody was dead in their 70s. But now your 80s or 90s, you're in my wound clinic, because a lifetime of chronic venous disease will give you an ulcer. So then you begin to change how you sort of look at these patients, because now you have to make another plan, right? As a surgeon, you got to have another plan. You have to have a better warranty on what you do. So I think the pivot, like I said, for me, was the patient, and the technology and the medicine changed. And our system, unfortunately, hasn't paid much attention to it.
Yeah, yeah. Good point. Good point. All right. So Reena, I know that you just started your company. Probably you're the in the early phase, but how are you looking at um, a private practice, and what you're developing? How does that work as a business? How are you thinking about it? I mean, I know that you're not fully launched yet and all that, but how are you thinking about it? Let's.
Fair enough. This is going to be a partnership with our physicians and their patients. So it is a dual mode that we are developing. Our launch initially is going to be with our physicians,
Hmm.
so that what we provide is a physician portal, and this could be most likely would be the primary care physician, but could also be the ophthalmologist, the cardiologist, the orthopedic surgeon. I mean, if as an ophthalmologist somebody's seeing cataract changes and you're like, you're so young, and everybody's talking about, longevity and anti-aging and so forth. You're the cardiologist and you're seeing some of that. You're like, okay, there's something else is going on. Let's kind of dig deep and so forth and see where you are with, whether it's just looking at HSCRP. Let's look at, other markers that we had essentially ignored for a while, or not know, rather than ignored, not known about as much, not focus, the LDL particle size, the ApoB, etc. Where are we with that? And what are the other targets we can build? So let's kind of bring that into mainstream medicine. Again, it might be the orthopedic surgeon who's seeing a hip fracture, is like, you're way too young. Where are we with this? And so forth. And what else in your body is also not, where are you on the biological age of that versus, your chronological age? So it is empowering these physicians who can jump on this platform, offer it to their patients, can get these tests done, can bring them back for these tests. So it is where this is fee for service. This is HSA, FSA, cash pay model. It's not getting into the insurance. It's not, at least at this stage, because though there could be some blood tests that could be done that your insurance might you should cover. But the point is, at early launch, we're keeping it here. And again, we're not replacing the physician. So the physician can continue to do whatever's covered, but we know a ton of this is not covered. Predictive analytics is not covered, and so forth. Together with that, what the physician's not alone. Tools with integrating the wearables, integrating the EMR, integrating these test results, providing, support. And I've started writing about the other LLM. I really do think that longevity and lifestyle medicine kind of go hand in hand. And I'm glad I got board certified in lifestyle medicine. There's no similar board certification in longevity medicine per se by American Board. There are a few other organizations that do that. But the point being that this is more of what we've done, but not everybody has the tools for better nutrition management, better stress management, better sleep management, and all of these other pillars that we have. So it's not one and done. You've done the test and you're done. This is BioTrax. Do the test, track that, follow up, and these are the tools where a physician could increase their revenue stream by doing this, as well as feel really, really good about taking good care of the patient with the latest that we have in our understanding.
So I'm guessing that it'll be like a service with a subscription, right?
Subscription model.
Yeah.
We're hoping to really, again, subscription model at a price that is very, very fair.
Yeah.
Very fair to our physicians and our patients.
So Paula, your business, UberDoc, I know a little bit about it because I've been
No more than a little bit.
because we've been talking every month about it.
Right.
But tell our audience what it is and what's the business. What is the business around and how does that help physicians?
So basically, we created a marketplace in direct pay care, direct pay specialty care. Let me start with defining a specialist as anyone who is boarded or trained in their specialty. So specialists of primary care. If you train in family practice, you are a specialist. If you train in pediatrics, you are a specialist. So we define a specialist as anyone who did training. So that's the UberDoc platform. So we wanted to just create a way for a patient to literally find a doctor nearby and available and make an appointment for a transparent price. So we took the insurance out of the equation. We take HSAs, FSAs, and credit cards and so forth, completely HIPAA compatible and so forth, both in person and telemedicine, whatever the doctor prefers. And so we started with some 6 core surgical specialties and then rapidly expanded to every specialty. We're in every state now, and we have thousands of doctors on the platform who basically all give me a seat in their waiting room for a direct pay patient, right next to their Medicare patient, their Medicaid patient, their Blue Cross. Give me one seat, like a house seat in your office for a direct pay. I've always felt the direct pay model made sense. So it was creating a marketplace. So we have the doctor side of the marketplace. On the patient side, we work with government agencies, people that need to buy a lot of appointments, and we're launching big to the consumer. My goal is to have every doctor. I want every single doctor, and we're completely system agnostic as well. Whether you're a doctor, obviously independent private practice doctors are easy to come on the platform, but I still want that academic doctor who is like being held behind a paywall with a bunch of facility charges for a patient to have access, and have that doctor have access to that patient. We have a lot of wonderfully young, trained, really well-trained people who, again, sit in an ivory tower behind a series of obstacles. So it's a mismatch. And so we're trying to just break those walls. I am a believer in the direct pay model. I think, Reena, you never want your things to ever go through insurance, because that's not right. Right? Because the insurance market is pivoting. We're the health savings accounts are doubling. People understand now there's a part of your insurance that will go to those high risk events. And then there's a part that should be held close to your heart and pay your primary care with, right? They should be 2 separate entities. The Medicare Part B should be a credit card, and the health savings, and the Medicare Part A is the insurance piece. We've allowed insurance companies to kind of overstep their boundaries in many, many ways. And I think that the costs of, just on the paper today, the insurance rates across the country are going up. The employer-based rates are like crazy, going up like 12, 15, 19% in Connecticut. And like crazy, like that's not affordable for employers. It's not going to have, it's just not affordable. So all that's going to go right onto the patient. So UberDoc really was about creating a marketplace, giving doctors the ability to be front and center to their patient. Just like me with my vein center, I realized that I wasn't going to sit around and wait for referral, because half my primary cares were changing teams constantly, right? Like, are you a Red Sox fan or a Yankee fan? It's like, well, I'm sorry, I don't remember who you were, right? I sent your patient to Yankee Stadium instead of Fenway Park. I'm in trouble now, right? And but because there aren't as many specialists as there were primaries, right? At that time, we were like we had to be in everybody's sandbox. So I didn't like that at all. So those network restrictions and everything else. So UberDoc was really created in part also because I knew, as a vein specialist and with a really good track record with wound care and everything else in the community, that I needed patients to find me. And how were they going to find me? And I didn't believe that they were going to have to wait to see their primary that they didn't even have, right, to get that referral, or they could find me on the internet. Yeah. So one of the early things we did with UberDoc was part of our absolute beta from the initial launch was to make sure every single doctor had a web page. They had a little web page that we were going to give them, and we didn't charge them, right? So that every single doctor could be on the internet. Hi, here we are, right? And here's who I am. And we allow the doctor to edit their own profile so that they don't have to pay millions of dollars to a web designer to create that for them. We want to make sure our doctors have those tools to do that. And many practices in some markets that we are their only web presence. So I think that part of it is that consumer, right? That direct to consumer that you have to do. And that was part of UberDoc. And the other part was just wanting to get a patient in front of a specialist quickly. And then from then on in, you can use insurance and get the referral, do all the rest afterwards, but just get them in the door first and make that assessment, because that's where you saw all the real issues that came in, with the anxiety of waiting on a breast lump, being misdiagnosed with things, spending lots and lots of money and time doing all sorts of things before you actually got into the room. And then you look at their leg and you diagnose them in like 30 seconds and like, oh my God, she's a genius. It's like, no, I see a million legs. Like, that's all I do, right? So I can diagnose you a mile away. So that's what UberDoc was. And that's how we, so it's really just, it's a marketplace. And we're excited to build that consumer part of that marketplace.
Great. Thank you. Veronica, same question. What is your business model for your clinic, for your practice?
Yeah.
How do you make money?
So I'm primarily a direct pay clinic, and I do take a couple of insurances. We've really been, I wouldn't say I have it all figured out for sure. I started out as direct pay and but still accepting Medicare because as many of you know, as a physician, if you opt out of Medicare, you can't always work in other places. So I actually really enjoy that population of patients though, and they really need my services and are often overlooked. So it's it's a little bit more of a hybrid model because most of the regenerative medicine services are not covered by any insurance. So even if
Mm,
we're taking their insurance for the initial visit or some of the rehab, they usually are paying direct for the treatments.
mm.
Other ways we make money is through membership model, which is something that we're expanding. And the membership is more around fitness and wellness and other parts of healthcare that don't always get integrated. Really expanding to more of a co-working slash marketplace model. So I'm looking to add in other revenue sources and not mainly just for the revenue, but for the way it can integrate things, products that we can offer patients and services that maybe are beyond our walls that we can bring in as a package.
Right. Um, so Paula, this question, how do you see your practice expanding in the future? What's the next step for you? What's the next frontier?
In terms of my private practice or Uber. so
Both.
So I should say I didn't answer your revenue model. UberDoc makes a transaction fee, and I should say that we don't make we're a transaction model. Ultimately, we want to pivot back to a SaaS model, which was started with other services that we could include, with marketing services or perhaps access to some technology that Reena and Veronica have, things like that we would offer doctors. So my private practice, so I'm at the point now where I'm a well-oiled machine. Worked with the same team forever. My nurse for 25 years just retired. She was an ICU nurse that was amazing, like it literally amazing. She's been my nurse since the day I came in the community. And I was very blessed. And so I really see succession. Like, I see that we built this Brain Vein Center. We want other younger people to come in and take advantage of what we've built. I see that as sort of where I'd like to see it go. It's very difficult right now economically. I think it's going to change a little bit. It was really, really hard these last few years. I don't know how the rest of you experienced it in other parts of the country, but Massachusetts was awful. A lot of practices went under. Massachusetts Medicaid pretty much didn't pay anybody for months and months. The Change Healthcare breach took its toll. Some of our best groups ended up selling to either private equity or the hospitals. They couldn't survive. And like our neurosurgical group, which is 60 years and had it all covered from the surgery to the neurologist to the physiatry to they owned the rehab, like they didn't make a mistake and they were superb clinically. It was too hard to keep the payroll and the health insurance going, right? I mean, that's really the cost of practice. The problem with consolidation is that it's really expensive when you sort of, it's very expensive. Why buy the cow when you get the milk for free, right? It's very expensive. So surviving all of that, I think we're going to come out the other end of it. But I don't know what's going to happen in the future in terms of when those deductibles go higher and higher, patients are really going to have to pay out of pocket for stuff, unless their premium comes down. It's got to come from something because it's a pretty big wage suppression right now. Healthcare really is a drag on wages and growth. So I would like to see my practice. I don't, grow through other people, bring some other young talent into the practice and take advantage of what we've built. Vein centers always knock on my door, private equity owned vein centers, and I'm like, okay, show me what you have, and if it's better than me, but at the end of the day, they don't change your payer mix.
Yeah.
They don't change your payer mix. They don't buy your catheters for less money. In fact, your cost actually doesn't go down; it goes up. So I'm like, okay, what about this model? Just explain to me. Oh, you don't have a headache. It's like, well, I've got everything pretty automated at this point. But then they're not, and we have to argue with the same insurances. It's not like nothing changes in the economic
Nothing
equation.
changes.
Nothing changes at all in the economic equation. So, it's just someone else is having that headache.
But don't you think there'll be more mouths to feed when these companies take over, so they have to squeeze some more?
Yeah, but again, the market's the market. I mean, Steward was in Massachusetts and they were nationally as well, but of course they squeezed and there was nothing left to squeeze, and then the hospitals all went bankrupt. So, you have to look at your market. You can only squeeze so much. So anyway,
Yeah.
that's what I would like to see. Young people, younger people with talent come in and support them the way I was supported, by my family to be able to do this, because we do good work, and somebody has to take care of me someday. I'm just saying.
Good answer. Veronica, how would you like to expand? What do you see the future of your practice?
Yeah, so I sort of touched on this before, but part of our expansion is going to be opening to other practitioners and making more of a co-working space for medical practitioners. And one of the biggest assets of my practice is the space. And so it is an open gym model with rooms around the edges, and I think it feels like a place where that kind of thing should happen. It doesn't feel like your typical doctor's office or hospital feel. And it also kind of lends itself to bringing in more community aspects to medicine, which I think if you're going to start a practice, and you didn't ask this question yet, but my one piece of advice is find something fun that you can have as part of the practice. Otherwise, all the headaches of running a clinic will just pile up and you'll wonder why you're doing it. So, the way that we're going to expand, aside from having more specialists in the space, is to have a membership model that allows people different tiers. One of the tiers will be to come into the space and use it like a boutique gym or recovery. So we have multiple things set up that people can use in a self-service model, for example, like compression, ice. We have Alter G, if you may not know what that is, it's an anti-gravity treadmill for people who are runners and they can't run. So, it's a space where we're trying to actually give people the tools to move better and not just tell them to do it. And we have the marketplace idea will be integrated into that as well. So that's what my true vision would be with that is also to have a place where other physicians that aren't able to go and do their own practice could come in and use the tools that I have. So, it's a lot of overhead to get your own shockwave machine and all your, things for P2P. But if I could create sort of a space where other people could plug in, then that's really giving power to this private practice movement that we're all part of.
Like a shared workplace. Are you thinking about opening more clinics, or do you want to consolidate everything in that place? How are you thinking about that?
I want to make this space really the hub, the model, and then I would love to expand. I think that honestly that takes a lot of capital, and that's not always something that you're going to get as a clinic,
Yeah.
be it more of a startup model, but there's rarely a VC that's going to just hand a clinic more money. So I see expansion maybe more initially as virtually, what things can we expand virtually, and then having offshoots in other places would be amazing.
Great. Thank you. Um, Reena, I can't ask you this question, but I know that you're just starting, and you'd like to have as many physicians as possible using what you're building. So this is the time where we open up our
You
questions.
know,
Do you want to comment?
though I will, yeah,
Yeah,
share with you our vision and my vision and our, game plan.
sure.
So you're absolutely right. We'd love to have as many physicians as possible join the platform. The platform currently provides, agentic AI tools, smart sets, digital dashboard, actionable insights. So it's a lot of clinical intellectual stuff that's built. But how do we see this grow beyond what where this would be, beyond tools for physicians and for the health conscious consumers, is to build ecosystem partnerships. So again, whether it is with sports medicine, whether it's with cardiology, whether it's, whatever that might be, bigger nutrition platform, a bigger fitness platform. So there's so much that we can do that not only that we can do that we know this, our patients need it, individuals need that to stay healthy. It's, you can't just say, hey, exercise, 30 minutes a day for maybe 5 days a week and you're pretty darn good. But no, they need nudges, they need support. The compliance is just not there. And we now are developing, we see tools there. So further ecosystem partnership and then increasing reach. I see that Paula's now in Canada. So would start off definitely based in the US. I mean, even just understanding what the different states require as far as, even simple diagnostic testing and everything that's allowed versus practice certifications and so forth. But that is where it is like, this is essentially longevity medicine, lifestyle medicine. It's universal. And if on an online platform, we really can support folks right across the world. So that's kind of how I see that,
Great.
having some impact across across a huge continuum.
Yeah, yeah. All right, it's time for questions from the audience. I know Susan is waiting patiently. So go ahead and unmute yourself and ask your question. And first, introduce yourself, please.
Okay, I'm a pediatrician. My name is Susan Gunduz, and I'm in Long Island, New York. I'm in private practice for about 30 plus years. I run a very busy pediatric practice. We see up 6 kids a day. I take private insurance, one third Medicaid. And we're very, very busy. And especially in August, it's just exhausting. I have had great difficulty, as well as my colleagues around the country, to get a pediatrician to come on board and join and work with me. We have agencies that come to us, they want to charge $200 an hour to place a pediatrician in my office. There's no way that that will be cost effective for me. So we had three, one moved, and now we have two. And we give a lot of time to each patient because we are private, independent, so we don't have anybody knocking on my door. But as soon as I leave, that's it. Nobody wants to take it. All the young people go straight into hospital equity or type of practices. They don't even knock on my door. They go straight to the hospital practices. I'm the only independent doctor in my area in Huntington. There's some about 10 miles away or 20 miles away. There's another practice. I'm proud of what we do. We can be creative. That's why the patients love us. We can think of different solutions because we're independent. So that's the advantage. And our Medicaid patients really love us because we can spend the time with them. And I'm proud of that we can do that.
What's your question for the panel?
How do they think that that's going to survive in practice? I don't see how a pediatrician could come into private practice and do what I'm doing today. That's not possible.
All
So,
right, who wants to take that?
so I think I saw your question in the chat. So, you're right. Young people are trained to want to be in the hospital, right? Get it? Not they've been convinced that it's too complicated to run a practice, right? Things are, but now, hey, with Chat GPT and AI, it may be a lot easier. A lot of practices, it really has to do with cash flow, right? It's just the process of billing, especially in a pediatrician office, right? You have a lot of claims, and those claims are not big claims, but there's a lot of claims, right? So your billing service prices are higher, right? They're much higher than like a surgeon's office. So your cost per patient is a lot higher. A lot of that could actually go away in a cash model. And I only say cash model because this doctor in Pennsylvania that, Chamini Wheeler went all in on a concierge pediatric practice. She didn't know what to expect, and she's been overwhelmed with how many families are thrilled, right? Because again, it's so hard to survive because there's so many networks, everything else, but patients do love the care, and your patients will follow you. So the only thing that you have to solve in this equation, or not you, but the system has to solve, is that Medicaid patient that comes to you, you have to submit a claim to Medicaid, right? To get paid. That's how it works, right? They have to, you imagine if they came in with that Medicaid card that was loaded like an EBT card and could tap and pay you at the time of service, right? There's absolutely no reason that can't happen, right? There's no reason. All that data that flies into the third world party and comes back down that's insecure means nothing. It's meaningless data. Nobody knows what to do with it. But at the point of care, especially in a pediatrician's office where everything is so predictable, and there have been some models out there where people have crossed from a publicly funded health center, the same group of people crossed the street and ran a clinic, and they realized if they just charged their patients $15 each, it was a lot easier. And because they were no longer federally funded, they didn't have to do all the paperwork. So I actually think that these models are going to take hold. And it isn't just going to take hold at the highest levels, it can actually take hold for those Medicaid patients. I was joking, if an EBT card can buy a sugary soda, it should be able to pay a dentist, right? It should be able to pay the pediatrician. It doesn't make any sense. So I think that some of these models are honestly not that far off. And I think that will bring it all back, because you cannot sustain the other model either, Susan. All of those doctors that are employed in these large institutions with all of these consolidated costs, that's not sustainable either, right? It's not, unless somehow pediatricians are somehow going to in hospitals are going to admit everybody again. It's just not going to be sustainable. So I actually I think that the equation can pivot the other direction. And I think most doctors, young doctors especially, would probably love to practice like yours. Be able to have the freedom to spend that time with the patient. But again, if you get rid of all that, the claims, all those millions of claims, right? At the end of the day, you have like 300 claims, and you need 300 people to process it. That's antiquated.
Anybody else want to take? Veronica?
Well, I think we just have to build practices that don't look like what they've always looked like, and then that's going to help further innovation. Because just like Paula says, if we just keep doing the same model, we're going to get the same results, and we need people to be innovators. I don't know how you find those people. You have to find people that are a little bit willing to take risks. Maybe people that have had exposure to some practices already and kind of are frustrated. Maybe that's your pool to find people. But I think it's not just you, Susan, that has that problem. So I think that if we're going to attract people, we need to make different types of practices for them to work in.
Hmm. Cool. All right. I see, unless Reena wants to chime in.
It's a tough one. It really is a tough one, and I see that in our colleagues that are outside this system I'd been in Kaiser, kind of protected. We had great benefits and so forth, and assured. Um, and the sad story I've heard for at least a decade now is where they joined a bigger health system, being promised you can practice exactly as you've been doing, which stays good for a year or two, and then the screws are turned. It's like you got to be that much more productive. You got to do this in this fashion, and so you're actually in a system that you never wanted to be, and you wanted to be, doing things your way. I think at the end of the day, it is the payment model. You're absolutely right, Paula. It is all about, I mean, healthcare is a business. So, how do we do that? And how do we carve out the kind of medicine we can do that is more efficient, can be virtual, can be done, with e-visits maybe, can be done with telephone visits, which don't cost as much or are way more, a less painful experience for the parents and the family to bring the child in. Hey, this could be done there. And then we absolutely, absolutely need the physician in the office. We know that medicine is not only about what are your clinical needs, but what do you want in the moment. You just need that reassurance that my little cough and congestion is okay, and no chat GPT, no Google MD could cover that. And so, patients are
Hmm.
going to find us somewhere. Hopefully, not as painfully, hopefully not with, hopefully this access issue improves. The access story from our patients, our colleagues, our friends and family that you hear is terrible. And yet there are physicians but they can't, sustain practices the way that it is currently. They really, I mean, quality of life's gone. You're cutting corners to make it work. The reimbursements are kind of, dwindling away. Where's the fairness in this equation? And I think so. A major revamp, and kudos to you guys, Paula, Veronica, for leading the way and showing, the different ways of doing this model. Hopefully, it can be done on a much different. They're trying value-based care. That didn't, where are we with that? So there's a lot to be done.
Okay, the value-based care was just that was nothing. That
Yeah.
was did not deliver.
Well, that was just another word for capitation, right? Like it's
Yes.
another. So really, in today's world, when you have individualized medicine, where that child has an appendix and goes home, right? We're not keeping them in the hospital, right? Your knee replacement, you're home. Your remote monitor, you're home. So remember, we have a different world. So who's paying for all that care at home? Right? You're not paying, so I always say that it's like, what are we funding? So this
Yeah.
concept of value-based care is if you have, yes, every patient that goes in through, like, I'm sure your Kaiser, you had very monitored thing. Patient came in, they were monitored, they had a, critical pathway, everyone got this and that. Well, that doesn't happen anymore. Right. So that worked at that time, but I can guarantee you those models will not work now. I'd be surprised if Kaiser's model would work other than unless they have a lot of private equity investments, which I'm sure they do. Like most of these big consolidated places, it's all, they're not making money from healthcare. They're making money
Mm.
from, their investments. And there's no honesty to that failed business model because nobody wants to say their balance sheet doesn't work, but it really doesn't. The balance sheet doesn't work anymore. But I do think that it works for the patient. And that's what they talk about, this patient-centered care. Patient-centered care, we used to be like, oh, put the patient in the center of this clinical model. It's like, no, hand the dollar to the patient. That's what
Mm.
patient-centered care means, that the patient drives it. Patient
Yeah.
drives it.
So there's one question in the chat. Deepa asks, how do you do cash pay with physicians who are still contracted with the insurance company.
That's a big myth. And patients on UberDoc, they sign a HIPAA form. As soon as you sign HIPAA, you give you can do anything you want. The doctor, it's a completely protected thing. Because yes, you're contracted to, like, not charge, for example, a Medicare patient. You can't charge a Medicare patient, but like on our platform, Medicare patients pay $50 and then you can bill Medicare. They just kind of skip the line, because you're not supposed to charge Medicare patients something they're entitled to. But honestly, all of this is like, there's no restrictions in any of this because patients have high deductible plans. I mean, my plan with Aetna is like $6,000 out of my pocket before anything. So that means every single one of those doctor visits are with your HSA, right? Because so many plans have really shifted, and that's a great big myth. They say, oh, you can't take cash, doctor. It's like, really? You can't take cash. And I'll tell you a funny story. When I was first launching UberDoc, this Partners is the big Massachusetts group. It's now Mass General Breakup, right? They're the biggest players. And actually, one of the hospitals brought us in. They like, this guy thought this was the greatest thing ever. Of course, he ended up leaving to go to Boston Scientific. But it took 6 months in their legal team to kind of like, is it okay to take cash? Is it not okay to take cash? And I said, okay, if you don't want to take cash, that's okay. I just want to make sure I understand. Mass General Hospital doesn't want to take cash. Mass General Hospital doesn't, believe in health savings account. That's okay. You're just insurance. You just want insurance. So we just want to make that clear. And of course, they're like, oh, no, we didn't say that. Because of course, they have a whole wing full of like international people that come in and pay cash. so it was really kind of funny how, like, they just, people who are like, so I guess it's like the brainwash, the purple Kool-Aid that you can't take cash. I think they want us to think that fee for service is bad, but in fact, we are a service industry and we get paid. So hello, we are fee for service. And remember, I always remind everybody, fee for service means transparency. As soon as you eliminate fee for service, you eliminate price transparency. They do not coexist. They do not coexist. In value-based care, there is no price transparency, right? There is no price transparency in a capitated model.
So you have them sign a HIPAA form?
If you have to sign a HIPAA form, allows the patient to say, you don't have to bill I allow you to charge me and not bill my insurance. Yes. Yeah. They give permission.
I'm going to give it a try.
Veronica?
It'll be wonderful, Susan. You have put a big price list, like an ice cream. This is our price list. Right? Don't be afraid.
Very small, which is that sometimes the words you use matter more. And I just say direct pay because you're directly paying me like you would other services that you get. And by taking out the word cash, I mean, because really nobody's giving me cash.
Right.
People are. Sometimes they're giving me cash, but very rarely they're paying with a credit card or whatever. But there's something just like people feel icky, or other people in medicine more feel icky saying the word cash. So I find saying direct pay kind of just easy.
Yes, in fact, we have the direct pay option because we are like, when we go to the consumer, we don't want to really go with UberDoc anymore. UberDoc is the name of our network, there's just too many bad things happen to Uber drivers these days. So, and I am defending my trademark, but still, the concept of direct pay, and we actually have that. We're talking about direct pay option, DPO, we called it once. Like, you have an HMO, a PPO. I have a DPO. What's that? I have a direct pay option, right? Because people like to have like names of things, right? So the direct pay option is definitely something that we have. And I actually have a URL, like I have a few of those direct pay option, direct pay healthcare. Because I agree with you 100%, Veronica. We don't use the word cash, but I like DPO. I think that sounds like HMO.
I like that.
Yeah, you like that.
We can give them a little card.
Right, exactly. Right. That's what we're hoping to do. Right.
You mean like a credit card, like a debit card?
Well, no, like your insurance card that has a chip in it, right?
Yeah.
I mean, it's the only card in your wallet without a chip. Hello? Like, why is that? Right.
I'm thinking Waymo Doc. What do you think, Paula?
Waymo Doc, right? I'm up for names. Like I said, direct pay, because everyone's like direct pay. I was like, I like DPO, right? It's the Uber Doc network. We can still be called Uber Docs because we're better than everybody, right? We're super docs, right? But we provide direct pay healthcare, right? Direct pay specialty care, direct pay, the DPC world, their direct, primary care, right? But it's just
So, so Susan Gunduz says that it is hard to bring young people or young doctors into private practice. Why do you think that is? Are they averse to doing the hard work of starting a practice? Because obviously there's a lot of upfront work. But you can join another private practice, right? What do you guys think? What the young doctors are thinking when it comes to private practice?
I don't
paying
think
back
it's
their
hard.
loans.
I don't I don't think it's hard work. I just think they are just afraid. Well, I can only speak for pediatrics. If you see Medicaid, you have a government vaccine, then you have the private vaccine. And the government monitors, they audit and they check your temperatures 24/7. And they come in to see how you're doing your vaccines. The private, they don't check. There's a lot of rules and regulations, and I think they're afraid. They're
Mm.
afraid that they're going to do something wrong. Um, they never come. There's another practice 20 miles away. He also can't find anybody. He has three other docs, and two are retiring.
Mm.
He doesn't know what to do.
Well,
I
I
think,
think one thing we could do for, oh, sorry, Paula.
no, go ahead, Brian.
I was going to say one thing we don't do is expose doctors who are training to what private practice could look like or
Right.
be. We give
That's it.
no business education. Like I didn't even understand insurance when I finished residency. I had no clue. So
100.
how would I want to start a business? And contrast that with other specialties, chiropractors, physical therapists, they get like a business kind of education and they're much less, much more likely to open their own practices. So I think we need to start weaving that into the education.
So one of the things I do with my surgical residents is I open my books. I sit them down. I say, here, you want to know? You want to know what do they pay for hernia? What do they pay for a gallbladder? It's like, I'll show you. I said, Medicare allowable. I mean, they don't really think of that. And they think of RVUs and all this other stuff. I think the societies have done a horrible job. And I'm going to criticize my own society, American College of Surgeons. They've done a terrible job in terms of, they were always, again, they do the work of God and they're housed in hospitals, right? Surgeons are housed in hospitals. But something happened when I was a resident. Every major hospital in Boston, the CEO was a surgeon. Okay, because the surgeons were always there in the ER, in the OR, on the floors, right? They were the backstop of everything, and somehow or another they lost that control. And with that lack of control, they kind of lost their way. And then so you end up with the surgeons having like little to say about what goes on in the hospital, and then they silo. They get super specialized, so they train these kids into doing like one thing, which if you think economically, and if you think of somebody who's been in practice as long as I have, if you put all your eggs in one disease basket and people stop smoking, for example, or take a cholesterol pill, you got to find another disease, right? Or with semaglutide, but they really sort of focus these kids training into silos, so that they really limit their ability to go into private practice or into a community practice, because they make them so specialized. They're going to do an endocrine fellowship. Well, where are you going to do endocrine surgery other than a tertiary care? Right? You just will never have enough volume to make a living. If you're going to just do that one thing. So I think that that because of the sort of we've lost a lot of control, and the response has been to sort of continue to enable it. and this training gets longer and longer and longer. It's like these kids are like 40 when they come out. It's like, what? I'm sorry, it's not that hard what we do. I don't need that much training. And it's so now, and then we get them so specialized that they can only work in that. So I think it's sort of a way to limit. It has limited growth a lot. At least in surgery, it has limited growth a lot. And so you have a lot fewer people who feel comfortable, even. Like Susan said, they're afraid. They feel comfortable going into a practice that isn't like supported by a giant institution.
Reena, did you have something to say?
And, point well taken. Few people are going into primary care. That's what I know more about. I work very closely with the residents. I was doing journal clubs every month till last year, working with residents, medical students, and so forth. I think what I see is more of a drive for a work-life balance in this younger generation. You know, I can date myself, but I do think that, sometime back we were more driven by this is my profession, supersedes other priorities and so forth, and you just put your heart and mind into that. But more and more, I shared an office with somebody who just came out of residency. I shared that for the last 4 or 5 years, um, and it's a completely different mindset. So private practice, and I've never done it myself, but I'd heard about the fact that you needed to work at least 60% or so to even just go even with your basic infrastructure costs and things like that. All of the insurance, the everything else that goes around it. And our physicians do want to walk away and say, I'm working, but I'm not giving up the rest of my life for that. And private practice, the way it's set up right now, especially the what I'm hearing from my colleagues, are that doesn't allow that. It's back to reimbursements. It's back to there isn't this balance between, and this is especially true for non-surgical specialty, practices. So the reimbursement for doing a tiny procedure, I mean, not to negate the importance of that, versus putting your mind to that, really coming up with a good diagnosis, the reimbursements are not equivalent. And hence, people in private practice, my colleagues are looking for, can we do Botox? Can we do fillers? What else can we do? And so I'm hoping, do some longevity biomarker testing to feel good instead of trying to now go learn how to do Botox and fillers and things like that, because reimbursements are kind of dwindling, and they're just like stretched like crazy. So
But I'll tell you, Reena, the reimbursements for procedures are way down too. I mean,
must be.
anywhere from like the average for general surgery is like 26%, like ridiculous, right?
How do you sustain
The
that?
margin for putting in a stent in an artery is now negative 22%. So it's like
How, who
so
wants
all
to do
the
that? Yeah,
reimbursements are and I 100% agree. Again, when the reimbursements are that low and everything else, the margins, it becomes like you're below the waterline on most of this stuff.
right.
And it becomes very frustrating. And it is 60%. As my dad used to say, you start working for yourself in September. You work for everyone else in the rest of the year. And you work for yourself then. But I do think again, a lot of this has to do with all the insurance regulations and the government regulations. And when you lift that, if you talk to DPC doctors, they love their life. They have a wonderful work-life balance because they can see fewer patients, have more time with their family, and do really, really good medicine. And
That's
I
so true.
think that is, I actually think that model has proven to be better for patients. So employers are beginning to look at that model and saying, hey, can our employer health plans want DPC doctors, which would include pediatricians and so forth. So I actually think that it's going to turn around because it's not, and the work life balance. The kids are like it's work-life balance until you have to pay a tuition, right? Or you have to pay your loan back, right? Because a lot of these kids are doing outside things. A lot of them have side gigs. If it's not moonlighting, one of the jokes is when I would get doctors to sign up for Uber Doctor, I said, you're willing to do Botox for like a few $100s. Why don't you just see a patient for $300? It's like that's what you're trained to do. I'm just saying, you could just see a patient for that. Why would you do something that's outside your specialty or outside what your comfort zone is? But yeah, I think the pendulum's got to come the other direction, because I don't think it's economically sustainable.
Well, thank you very much, guys. This has been a great discussion, and we are coming to an end. Reena, I think there are a few questions for you. Sorry, Shaluza, we couldn't get to those questions yet. But Reena, if you can answer or leave your contact information, I'm sure they'll be happy to follow up. But before we close this session, I would like to thank you all very much, for sharing your expertise and experiences and wisdom. A lot of the young doctors that are coming on, or people who have been burnt out with, from systems, they need some wisdom and guidance and assurance that they're going to be okay. um, with that, I'd like to give you one last opportunity. What is one thing that you'd like to leave, your words of wisdom or advice for doctors that are looking into private practice? Let's start with Veronica.
One piece
Don't
of
say just do it.
well, I would say know your why before you get into it, because as you've seen, it's not a get rich quick scheme. And if you have that sort of passion and drive for a specific area that you're in or something that you're building, it's going to help carry you through the difficult times. And I think I said my other one before, which is try to have fun, do something fun in your office, whether it's, happy hour or a dance party or something that gets you and your patients like excited to be there. I think that
Mm,
if we all make medicine a little bit less serious and scary, that I think everybody would benefit.
good advice. Good advice. Rena, what's your advice for physicians
I,
who are starting off or wanting to do private practice?
I think what we do need is to use technology in a whole different way. And may not have been taught in medical school while they were in medical school. ChatGPT, Claude, all of these tools came along in just the last year or two, and they have to be incorporated. Agentic AI has to be incorporated. Technology has to, so kind of embracing that, growing with that. Those are real essentials. And stay in touch with us. Happy to, actually, and for me, learn with you, grow with you, all of that. So those are the opportunities I see, and invest with us also.
Yeah, I was gonna
Oh,
say, add on
Paula.
that real quick what Rena said, like look outside your specialty for tools outside of medicine, because there are things that you can apply to medicine that are being used in other industries. And if we just stay in our little bubble, we won't learn them.
Yeah, yeah. Expand your horizon, expand your thinking. Paula?
I think it's easy to work for the patient, right? You think about who you work for. You work for the patient. You're not working for another entity. You're not working for the Brigham or Kaiser or a private equity. You're working for the patient. And that's a very pure relationship to have. And that's the best one with the trust. And it's also the most economically viable one. So that's all I can say is when people are afraid to do private practice, it's like, just run the numbers. It's just a balance sheet like everything else. And the mystery, people like to cloak insurance companies and mystery and all this stuff. But at the end of the day, there's a bill, there's a claim, and you just got to make sure that you're paid for what you do, right? And if you have to collect a copay, you collect the copay. Yes, it sounds like you need an MBA for that. Not really. It's just like a cupcake shop. You got to make sure you have enough to make your cupcakes and you sell your cupcakes and someone's going to buy them, right? But I do think that I encourage people to put private practice up there next to, unless you're academic, it's a different world, right? But if you're a non-academic doctor, there's no reason why you shouldn't try to, go into some type of private practice in the future. I think for certainly primary care. If I were a primary care physician, family practitioner, you know, the group I work with out of the health center, one fellow said, I just want to open my own practice. I only dreamed about hanging a shingle in a little town and take care of the people. And you know what his attending said? Oh, you can't do that. Can't be done. It's like, we got to stop that, right? We got to stop right there and not teach residents it can't be done. And I think that narrative has to change, and it will.
Great. All right. Thank you very much, everyone. Thank you very much to the panel. And it's been great chatting with you. And it's a pleasure. Stay connected, stay in touch. And for the folks in the audience, please join our sessions. Please join our membership, of course. And there are some exciting new events coming up. So stay tuned. Thank you very much and good night.
Take care.